I'm Dr. Francine Foss, Professor of Medicine at Yale University School of Medicine, and I'd like to talk to you today about stem cell transplantation in cutaneous T-cell lymphoma. What is stem cell transplantation? Basically, stem cell transplantation is when we take bone marrow progenitor stem cells from one patient and give them to another. All stem cell transplants involve the use of these progenitor cells, which are obtained either from the bone marrow or from the peripheral blood, or in some cases from umbilical cords. Stem cells are produced in the bone marrow, and it's the stem cells that give rise to all of our cells, our red cells, our white cells, and our platelets. Within the bone marrow, these stem cells require growth factors to help them to differentiate into these different types of cells. And there are different growth factors that lead to red cells, platelets, and white cells. Stem cells actually, although they live in the bone marrow, are able to circulate in the peripheral blood. So if you actually look in the bloodstream at any moment in time, you can find a very small number of these stem cells. Very hard to find them, but you actually can see them in the blood. It turns out that certain growth factors, such as Neupogen or Neulasta, can stimulate the production of these stem cells and also mobilizes them into the bloodstream. So if you get a dose of Neulasta, say after your chemotherapy, what happens is that it increases the production of the stem cells, but also, in addition to that, it actually pushes them into the bloodstream. So that you can see how, if we use these growth factors, we can increase the number of circulating stem cells, and that will help us in terms of harvesting those stem cells from the blood. So what are the different types of transplant? There are two basically types of transplant, and that it depends on really what the source of the stem cells are. Autologous transplant involves autologous stem cells obtained from the patient, him or herself. These are obtained usually after the patient has had chemotherapy and or if the patient is in remission at that time. So generally what happens with autologous stem cells is that we're able to get these cells from the peripheral blood after we give, as I said, the Neupogen or the Neulasta. And so usually after the patient has had 4 or 5 cycles of chemotherapy and PET scan shows that they're in remission, for that last cycle of chemotherapy, what we will do is we will try to actually collect the stem cells that get mobilized into the peripheral blood when we give the Neulasta on that cycle of therapy. Allogeneic stem cells are a little bit trickier because they come from somebody else. They are not from the same patient. Allogeneic stem cells have to come from a patient that matches the patient in question, and we'll talk a little bit about that. That involves what we call HLA typing, looking for common proteins on the surface of white cells that are common between the donor and the recipient. So as I mentioned, most of our stem cells come from peripheral blood now. It's very rare that we actually harvest stem cells from bone marrow anymore. The stem cells have to be mobilized into the bloodstream, and I mentioned that we use growth factors such as Neupogen and Neulasta to do that. More recently, we have another growth factor that's entered the scene called plerixafor. So Neupogen and Neulasta are capable of mobilizing a certain number of cells to a certain extent. However, we found that if you add plerixafor, another growth factor, to this combination, you can actually then mobilize more stem cells quicker. And so it's not at all uncommon nowadays that we use both Neupogen and plerixafor to do the stem cell harvest. We can also harvest those stem cells from chemotherapy because chemotherapy itself, for instance, the drug cyclophosphamide, can actually help to push these stem cells into the bloodstream as well. In fact, cyclophosphamide is oftentimes used either with growth factors or sometimes by itself to harvest those stem cells to get them into the blood. Okay, what is the process of stem cell harvest and reinfusion? So as I mentioned, most of our stem cells come from peripheral blood. So what happens is that the patient receives the growth factors to mobilize the stem cells into their blood. Then the patient comes into the blood bank and they get hooked up to a machine like they're donating blood. This machine is capable of basically identifying and spinning out all of the white blood cells that include the CD34 positive stem cells. It collects multiple types of cells within that stem cell product. So it basically collects all the white cells, and all the red cells go back into the patient. Now, that stem cell collection includes stem cells, but it also includes T cells. It includes other types of cells. So in some cases, the T cells are actually depleted from the stem cell product using antibodies so that we only have stem cells in the bag. Now, this is only done usually in certain instances where it's important to get the T cells out. It would not be important at all in autologous stem cell transplant, but it is sometimes important with allogeneic transplant where you get cells from somebody else. And this is just an example of what one of those stem cell processing machines looks like. So after we harvest the stem cells, they need to be frozen so that they can then be transported or frozen until the patient is ready to receive them. So the stem cells are basically put into a solution called DMSO, and they go into the freezer for an indefinite period of time, hopefully not that long. When the patient is ready to receive the cells are washed, they're thawed and they're washed, and they're tested for bacterial contamination prior to being reinfused into the patient. And the reinfusion process is basically like getting a blood transfusion. Because there might be some residual DMSO, which is a chemical preservative, in these cells, even though they've been washed, sometimes you can actually smell that DMSO in the room during the course of the infusion, and sometimes patients can react to it, but those reactions are not severe or significant. So in the case of autologous transplant, where you give yourself back your own cells, these cells are almost always frozen down. However, in the case of allogeneic transplant, where there's a donor donating the cells, sometimes what will happen is the cells will be donated fresh. They'll be donated and then given right to the patient without being frozen. And the reason for that is that every time you freeze the cells, you end up losing some of them as you're freezing and thawing them. Now, ever since COVID, the whole COVID situation came upon us, we've basically had to freeze cells and not been able to give them fresh. It used to be that, say, for instance, the donor was in Milwaukee and the patient was in New Haven. The donor would donate the cells. They would actually get put on an airplane and flown directly to us. We would get them and infuse them the same day or the following morning into the patient. So they never got frozen. Nowadays, as I said, post-COVID and during COVID, we've pretty much been freezing all of our cell products because you really couldn't rely on that transportation during COVID. And effectively, that hasn't made a huge difference, but it's just a little bit of a change in our practice. So in order to get a transplant from somebody else, not yourself, we have to find somebody that matches you. The matching is based on what we call HLA typing. So the HLA genes are proteins that are expressed on the surface of lymphocytes and other cells in the body. These are different types of proteins that govern the immune responses to different foreign materials. And each HLA locus is represented by different alleles. And so, for instance, there's HLA A, B, C, and then the HLA-D locus. And so within each one of these, there may be many, many, many different subtypes for HLA-A, C, and B. So you can imagine that there are multiple possibilities, and you can imagine that it could be quite complicated to actually match somebody to all of these different alleles. HLA matching involves 10 alleles, so HLA A, B, C, D, R, and DQ. So basically each one of these, there are 2 different chromosomes that we each have. So each one of these is represented on each of the 2 chromosomes. So 5 times 2 is 10, which is how we get the 10 out of 10 match. And again, this is a very complicated procedure that's actually done by computers. So HLA typing is done from the blood, of the patient, but also from the saliva of the donor. So if people want to donate and they go to a bone marrow transplant donor drive in their community, what will happen is that we will, generally speaking, we'll get saliva, and our DNA can be typed from that saliva. So we can figure out what the HLA typing is just from that saliva. Our patients generally get a blood sample drawn, and again, we do the HLA typing from the blood. And a perfect match is a 10 out of 10 donor, either a family member or an unrelated donor. Now, if we can't find a 10 out of 10 match, sometimes we can find a 9 out of 10 match. 9 out of 10 is just as good as 10 out of 10 within the conventional world using the different types of immunosuppression and other medications that we have. A 9 out of 10 donor is perfectly fine. In addition, more recently, we've been able to do haploidentical transplants. So a haplotransplant is 5 out of 10. So basically, the people that would be potential haplo matches would be a parent, a child, or a cousin. So if you think about it, the best match you're going to get from one of your parents is going to be a half match. And likewise from your child, because your child is only 50% you and 50%, they're your spouse. And it never used to be that these matches were good enough. But recently, we're able to do these haplotransplants because of different methods of immunosuppression. So you'll hear the term HLA, and basically this is what we're talking about. And again, all of this is very complicated, and it's done by computers. So it turns out that the National Marrow Donor Program is actually the vehicle by which we are able to do transplants, because the National Marrow Donor Program, established in 1987, basically does donor drives and identifies people who want to put their DNA into the registry and be potential donors. And so the National Marrow Donor Program has facilitated a significant number of transplants, 2,500 transplants annually. A third of them are for children. And only about a third of patients who need a donor find one in their family. And so 70% of them rely on the registry. And so basically, if you're looking for a match, you have a 1 in 3 chance that you're going to find one within family members. And so again, for many of our patients, this bone marrow transplant registry is critical in their ability to actually get a stem cell transplant. And so currently the number of donors and the number of cord blood units in the database is 10 million. And I just want to stress that this is an international registry as well. In fact, many of our donors actually come from Europe, from Germany, because in Germany, most of the young people in their 20s will put their DNA into the bank. What we don't have is we don't have a significant number of patients from minority or disadvantaged, disparate backgrounds in this registry. And so that's a problem for patients who have that kind of a genetic background, that we may not actually have good representation and be able to find them matches. So there's an organization called the Center for International Bone Marrow Transplant Registries. So this is actually the actual registry that collects the data on all of the transplants that are done in the United States, and collaborates with registries in Europe and around the world as well. And so this organization literally has data on just about every transplant that's done in the United States, and they're able to actually track all of that data. So if you go to their website, cibmtr.org, you actually can access a tremendous amount of data about stem cell transplantation. In different diseases, it's broken down by disease, it's broken down by age, it's broken down by type of transplant, et cetera, et cetera. So I'm just kind of showing you this one slide to just show you the different types of transplants and how things have changed over time. So basically, in the modern era, what's happened is haplotransplant, which is shown in blue, you could see before 2013, pretty much not done at all. With the new discoveries about how to manage rejection and graft versus host disease, the number of haplotransplants has really skyrocketed. to about 2,000 per year in the United States. It's a high number. And then likewise, the number of match-related donor transplants actually has kind of gone down a little bit. And, one of the reasons for that is that people aren't having big families anymore. So in many cases, there may not be siblings in the family to type. And the matched unrelated donors have actually gone up. And I think this also reflects the fact that more people are going to donor drives and more people are putting their DNA in. There are more donors available for people. So again, this is all very important data for people to understand, and how important it is for us to really think about this if there's a donor drive in your community. So what about allogeneic transplant and cutaneous T-cell lymphoma? How do we identify patients who are candidates for transplant? What are the outcomes after transplant? What have we learned about different transplant protocols that are important in terms of knowing the best way to do the transplant? And then what if patients relapse after transplant? So these are all the important questions that we are asking ourselves, those of us who are experts in the field. And we don't have good answers for some of these questions, but the good news is that we're now starting to put data together from a number of different transplant centers and trying to actually figure out if we can optimize this for patients. So what I'm showing you here actually is the actual data. So I was working with a couple of colleagues in other institutions to initiate this effort to basically try to look at all of the data on allogeneic transplant and cutaneous T-cell lymphoma that's been reported and written up in the literature, try to pull all of this data together, try to make sense of all of this data, and then try to figure out what can we learn from this data about how we should do these transplants, who should get transplanted. And what I basically want to show you is that the number of patients that have had transplant is perhaps a little bit less than I would have expected. So in this, and you can see the number of studies we looked at. You can see European study, MD Anderson, the City of Hope, Japan, Yale, Stanford, Australia, etc., Turkey. You can see the different centers represented here. So 254 patients had MF and 150 had Sézary. You can see the breakdown by gender. And most of these patients had a follow-up of about 3 years. And the time from diagnosis to transplant was interesting. So it was 28 months median, but the range was from 12 to 47 months. So this slide just shows you some of that data. And what we basically learned from looking across all these studies is that about a third of the patients who had transplants, about 40% of the patients that had transplants, actually were alive after 3 years. And so these were really success stories for these patients. If you look at the number of patients that relapsed, actually the number was about 40%, or give or take, across these different studies. And if you look at the number of patients that had complications from transplant, the numbers here that I'm showing, 40% with graft versus host disease, but very few with severe graft versus host disease, are pretty much what you would expect from any kind of allogeneic transplant, so not specific to CTCL. And I think what we're learning here now is that we have about 40% of our patients that actually do well and are cured with allogeneic transplant. So now what we want to do is actually drill down in more detail and look at this 40% versus those who didn't do so well, and see whether or not there were specific characteristics. So did they have tumors? Did they have erythroderma? How many prior therapies did they have? Did it matter how old they were? So there's lots and lots of questions that now can be answered and kind of dug out of this database. So what we're actually trying to do now, and I think this is going to be an important contribution for the field and also for our patients, is we're trying to, again, assess the outcomes in this database by looking at specific things. looking at HLA typing, looking at matches, looking at regimens, looking at supportive care and other things, and trying to figure out how we can actually optimize this. So what we're actually trying to do is establish guidelines and parameters for allogeneic transplant in mycosis fungoides and Sézary syndrome. And I mentioned different conditioning regimens prior to transplant, how you prevent graft versus host disease, what's important to know about that. The time from diagnosis to transplant is going to be important. So should we be doing transplant early in the course of disease or later on? Do patients need to be in remission at the time of transplant? Is that important? And then if they relapse, should we be giving them donor cells again? Should we be giving them donor T cells, which can be done for patients that relapse? And how important is that? And so this effort to try to coordinate this and establish these standards has been done as a collaboration with all the different transplant centers in the United States. We're actually about to publish our guidelines paper, which will come out in the Bone Marrow Transplant Journal in the next month or two. And again, this is going to be a clinical practice guidelines for allogeneic transplant. And I think what's important about this is that it's one thing if you're a patient at a major center that sees a lot of cutaneous T-cell lymphoma, such as Yale or MD Anderson or Memorial Sloan Kettering. But if you're at a center that doesn't see a lot of these patients, it's important for us to give guidelines for those transplant doctors and those oncologists as far as which patients should be considered for transplant. Because I think what's happening is that many of our patients aren't even considered for this potentially curative modality, and we want to really move the needle on that. Well, I just want to drill down on some details for you to show you a little bit about what the actual outcomes are for individual patients with this disease, with transplant. And I'm going to talk about MD Anderson, and then I'll mention our data at Yale. So MD Anderson reported 47 patients who underwent transplant from 2001 to 2013. Now, a lot has happened in that period of time as far as our ability to manage transplant complications. So I think that what was true earlier on may not be true even today. At that point in time, what they learned, though, is that the use of total skin electron beam radiation before transplant made a really big difference. So if you actually radiate the skin and get the skin as clear as possible, many of those patients actually did better. And when the patients that they transplanted, most of them actually had more advanced disease. And so they had Sézary syndrome with a lot of blood involvement. That was the major group. They had involvement of liver or other organs, bone marrow, for instance. They didn't have that many patients who just had patches and plaques. So the earliest stage patients were not well represented, of course, because they would not be the ones you would want to transplant. So the median time from diagnosis to transplant ranged from 11 months to a very long period of time. And so again, I think the median was about 4 or 5 years. Perhaps we actually should do better than that, and perhaps we should be thinking about it sooner. The disease status at the time of transplant, so only half of the patients were in complete response. So again, just because you're not in complete response doesn't mean you can't go for a transplant. If you look at the donors, sibling donors in 44%, matched unrelated donors from the registry in 50% of the patients. As I mentioned, the importance of total skin radiation, 89% of the patients had that. The complication of transplant is the graft versus host disease rejection issue. It occurred in 40% of their patients, but the severe version of this only in 10%. And the chronic graft versus host disease was 28%. And it turns out that the patients who had total skin radiation actually did pretty well. And what we now have learned from this is that total skin radiation is pretty much considered to be a standard in patients undergoing transplant. It also turned out that the Sézary patients did better than some of the MF patients. So the ones that you thought would have the worst disease the Sézary patients actually turned out to actually do very well with transplant. And there are a number of different trials that have shown the same exact thing. So I'm showing some data from Yale where we're showing our 22 patients that underwent allotransplant with CTCL. And if you just look at the different stages of those patients, again, many of these patients had advanced stage 4 disease. They had Sézary syndrome. Many of them had cutaneous tumors. They had lymph node involvement as well. And if you look at the year from the diagnosis to bone marrow transplant, you can see the range. This patient was 10 years. Some of these patients were only a year because they had very aggressive disease. But you can see that it was variable. And the other thing I wanted to point out is the amount of therapy that these patients had prior to transplant. Many of these patients had to have chemotherapy. They had to have these aggressive EPOCH and CHOP kind of treatments because their disease was really refractory. Nevertheless, despite having these very aggressive treatments, these patients were able to make it to stem cell transplant, and many of them actually did very well. And again, we tried to use total skin radiation in as many patients as we could prior to the transplant. And then, like the MD Anderson experience, a number of our patients were not in complete response. So you can see the number of patients who only had a partial response who went on to transplant. And you can also see that it's a mixture of different kind of donors. And we're now also including some haplo patients as well. And we had a special conditioning regimen that we used with pennistatin and total body radiation for most of them. So basically 17 of our patients had the total skin radiation before transplant. Now, if we look at our Sézary patients, 12 of these patients are actually alive 5 years later. 8 of them are in complete response. So 8 out of 12 are in complete response. And this is, I think, is a really big number. The overall survival is 75%. The disease-free survival, which means that the lymphoma didn't come back, is 62%. So I think, if you're looking at patients, as you saw these patients with very advanced cutaneous lymphoma, had lots of therapy, had combination chemotherapy, pretty much everything that we could do. At the end of the day, the overall survival after transplant, 75%. So I think that we really need to seriously be considering this for many of our patients and probably earlier on than what we are considering it for. Okay, so it turns out that there was no difference whether you had this transplant earlier or later. If you look at less than versus greater than 3 years from your diagnosis, the outcome was the same in those that had it less than and those that had greater than 3 years from diagnosis. And also, there was no difference whether you had a complete response or a partial response at the time of transplant. And so, again, that was very interesting because typically we think that, oh, you have to have a complete response before you can go to allotransplant. Well, it turns out that's not true. So what about the haplotransplants? We only had 4 of these patients. And one problem with haplo is that patients can relapse early. But it turns out that 2 of the patients that relapsed actually went into remission again right away when we used brentuximab vedotin. So we gave them a few doses of brentuximab, and now they're in remission. One of those patients actually had a second transplant. So again, I think that our data shows what MD Anderson showed, which is that transplant is possible even in patients with advanced disease, even in patients who've had lots of prior therapy, even in patients who are not in complete remission at the time of transplant. And that it certainly is something that we need to be considering. Okay, so where do we go from here? So we know that allogeneic transplant is a potentially curative modality for CTCL, even advanced patients. We also know that the use of skin radiation before transplant can improve the outcomes, and I think should be done, if possible, in most patients. We've also seen that the Sézary patients do particularly well with transplant, so maybe we should be considering those patients for transplant earlier. And if we look across all of our data, the patients who should be considered for transplant include those with more advanced tumor stage disease. I mentioned the Sézary syndrome, I didn't talk about large cell transformation, but that was another factor that correlated with a good outcome. Progression after multiple systemic therapies, and then also younger patients with more aggressive clinical course. So people that fall into these categories ought to at least be considered for transplant. Doesn't mean that they would have a transplant, but at least you should discuss it with your physician, and it should be something that perhaps you think about it at some time during the course of your disease. The availability of haplodonors has made transplant available to a larger number of patients. So again, a third of patients can have a family donor, 70% of patients can find a donor in the registry. Haplodonors can be used, which are, again, the family members, children, parents, cousins, in patients who don't have other donors. And then finally, we've been able to put together a set of guidelines, which reviewed some of the things we talked about today. And we're going to publish those consensus guidelines so that there'll be some standard for the use of transplant in cutaneous T-cell lymphoma.